See this man with enormous lymphosarcoma, and here it is having disappeared. And that was promulgated by this gentleman, the Yale University, and for the first time they looked at patients with particularly lymphoid tumors, and 27 were treated, the majority advanced or terminal stage, resistant to radiation, every age some benefit. The first really established observation that chemotherapy may make a difference. In our own institution, this was then developed, was the utilization of a new antimetabolite, the first use of 6-mercaptopurine by these people here, Joe Birchinall, David Konofsky, who developed a system for describing the performance status. Now that's interesting because at that time acute leukemia, of course, was completely lethal. Every child that developed leukemia died. And they, for the first time, noticed hematological and clinical remissions after 2 to 9 weeks of therapy. It doesn't sound very great to write these remissions last from 2 to 22 weeks, but remember at that time there'd never been anything that worked for childhood leukemia. And they went on to develop it. At that time, this was our hospital. In 1975, it was changed in its name, typical of what can happen in New York. Now, at the same time that these people were developing in our institution chemotherapy, this gentleman was arguing for even more aggressive surgery. So at the same time, in the same institution, you had people developing a new approach to treatment, and here were the surgeons arguing for even more extensive and radical surgery, which we now know, of course, was not appropriate. Now, it's interesting, you heard that I was born in New Zealand, but one of the very first people to propose less aggressive surgery was this gentleman. This is the Olympic Games in 1924, and he ran third in the 100 meters. And those of you will know that this was the basis of the movie Chariots of Fire. Now, it's even more interesting because this gentleman here, Eric Liddell, a Scotsman, who won the 400 meters, was really supposed to run in this race, which it's predicted he would have won. Thereby, Porritt would not have even been on that. He didn't run because his religious beliefs would not allow him to run in the heats, which were held on a Sunday. Now, Porritt was one of the first people to propose conservative approaches to breast cancer. And he wrote in a paper independently published 1964, summing up without decreasing survival, very important, a simple method of treatment employed, eliminated deformity and reduced morbidity. And that was at that time this combination of conservative surgery and on occasions radiation was proposed. He was a man of some insight. He said it's simple, down to earth, and thereby contentious. Thinking again, each time we have a simple idea, people say, well, it's too simple, it's not correct. He made the observation, which I hope I've emphasized, that knowledge of the essential nature of neoplasia, each growth has peculiar to itself. And we now know that. It's not just the tumor the patient has, it's the kind of tumor, it's the kind of patient, and the scenario in which it occurs. Now, to put that in context, in the United States, the first person to enter into a randomized trial comparing aggressive surgery or comparing lumpectomy didn't occur until 1976, and he had wrote about this as an observation in the 60s. So the important observation there is that we tend sometimes to forget what's taken place in history. This gentleman was a breast surgeon at our institution, this man was a pathologist, and they made the observation, in fact, that these super radical operations, including surgery and radiation, resulted actually in the consequences of another kind of cancer. So this lymphedema created an environment in which cancer developed. You can see this is the first edition of the journal Cancer in 1948. Remember, I was talking about less aggressive surgery by Porritt in the 60s. This is the kind of terrible tumor. This is a patient of mine where they've got a large lymphodematous arm. They've had a radical mastectomy. They developed these very aggressive tumors. Now, these are not radiation-induced. These are lymphedema-induced because there's a tumor there, and that's well away from the radiation field. And this patient will go on to die of that disease. Now, why is that important? Well, one of our problems, of course, in the United States is that we overtreat DCIS. We overtreat ductal carcinoma in situ with the breast. Now, it's very true. Randomized trials of radiation for DCIS clearly show a benefit in local recurrence. That's unequivocal. But it doesn't change the metastatic rate. So you have to be very careful not to overinterpret this. More importantly, that most of these local recurrences can reoccur. And I don't want to bore you with the mathematics, but the benefit overall is actually very small. It's only about 1% in terms of any subsequent benefit. This says the same thing. Now, the other side effect of radiation therapy, of course, is that particularly inappropriately delivered radiation has associations for others, including this entity, soft tissue sarcoma, which you heard I've been interested in for a very long time. And what happens is that this woman who's being treated develops this terrible tumor involving it. It's resect the chest wall, put it back together, but she recurs, and of course that will cost her life. That's been established by the Institute Curie, a prominent institution. Now, I want to make the emphasis, this is a rare complication, but it's real, and we think it's about 5 in 1,000. So it's not to say that you shouldn't receive a radiation, but to begin this idea that we should begin to be a little more self-critical about where we apply these therapies. That's a problem for us because the prevalence of this ductal carcinoma in situ, which really is a benign disease. Almost nobody dies of this disease. The diagnosis has increased markedly.